Good morning, everybody. Are you all able to hear me in Hall B?
Yes, sir.
We'll start off with the program, and we have some very good papers here. We'll start off with that session. I just want to tell our AV team to let the whole paper play, and then we can ask questions. We have just one session here, and after that we will be only conducting the program in Hall A. And this is a free paper session here. The first paper is by Dr. Abhinandan Reddy on the analysis of cervical morphometric parameters on dynamic MRI in cervical myopathy patients. Please play his paper.
Good morning, everyone. I'm speaking on dynamic MRI in cervical myopathy patients. Cervical spinal cord could be dynamically compressed, and neutral MR images may not fully reflect the dynamic spinal cord compression. And both static as well as dynamic factors contribute to the pathogenesis of the cervical spondylitic myopathy. And cervical spinal cord undergoes repetitive injury during the cervical motion, which may adversely affect the clinical course. The severity of the dynamic stenosis may be a predictive factor for the mild CSM progression. To date, pre-operative cervical spondylitic myopathy evaluation is based on MRI performed in neutral position, and the application of dynamic MRI for clinical decision making is not a pre-operative routine procedure. To maximize the chances of recovery cervical decompression, it is important to determine the pre-operatively the exact number of levels of cervical spine to be decompressed. And we think dynamic MRI can lead to a modification in the surgical plan based on the neutral MRI and more levels that should be treated. It is a single-center retrospective study, and patients with myelopathy and myeloradiculopathy have been included, and patients with history of previous surgery to cervical spine trauma tumors have been excluded. Angio-scare and Mooley classification have been used in the present study, and as the picture depicts, we have taken MRI in flexion and extension using a cushion underneath, so as to produce flexion and extension at the cervical spine. And morphometric analysis was performed in neutral flexion and extension positions, and the tightest area of the spinal canal was defined as the compressed level. Anterior length of the cord, posterior length of the cord, spinal cord area have been calculated and analyzed. As you can see on the image, the length of the spinal cord anteriorly and posteriorly have been assessed in all the different positions of the cervical spine. And the statistical analysis was done, and all the results were presented as mean and standard deviation. These are few representative cases where we can see on flexion and extension the amount of compression and change in the cervical spinal diameter and the compression from the anterior and posterior. And this is the post-operative picture with change in plan. This is another case with similar compression on anterior and posterior using cervical spine dynamic MRI, and the change in plan to posterior only to decompress the cord. Similarly, this is another case showing dynamic cervical cord compression. So we assessed around 100 patients with a mean age of 58 years, and significant differences were found in the spinal cord area, posterior length of the cord, and cervical cord angle. And MJ square positively correlated with the age and negatively with the spinal cord area. And posterior length of the cord was the maximum and least in the extension, and the differences in all positions were significant. And significant differences were noted in the spinal cord area as well in extension and neutral positions. And the distribution of Mooley grades revealed a discrepancy between neutral as well as extension. And grade 2-3 increased significantly in extension. Also, the difference was especially marked at grade 0. On dynamic MR examinations, it was seen that central canal widened by an average of 14.9 degrees during flexion and narrowed by 13.4% during extension. And dynamic MR examination was found to be particularly helpful in imaging the dynamic causes of the myopathy etiology. Although instability was suspected in 20.6% of the cases according to ordinary X-ray, instability was found in 41.3% of the cases using dynamic MR image examinations. This study provides objective analysis of radiological changes in the stenotic cervical spine in static and dynamic positions. However, the various factors such as patient age, baseline neurological function, rate of deterioration, severity of symptoms, and overall health should be considered together. Extension MR images were clinically applied to determine the surgical levels for cervical decompression. A major finding of the study is that 50% of the patients were classified to high grades, but only 35% were classified as high grade in neutral, and grade 0 was 3 times more often in the neutral position than in extension. This means that levels that show partial obliteration of subarachnoid space in the neutral position can show impingement of the cord in extension. So, if the dynamic MRI had not been done preoperatively, majority stenosis would have not been decompressed surgically, and this may have dramatic results on the post-operative result. Preoperative dynamic MRI can be of great value to determine the accurate decompression levels of cervical spondylitic myopathy. It leads to a modification of the initial surgical strategy based on the neutral MRI. So limitations, it was a retrospective study and MRI was performed in the patients in supine position. Results may differ in the upright position, and due to limitations of the time and cost, axial images were not acquired in the dynamic positions. In conclusion, dynamic MRI helps to identify significant cervical canal stenosis that are partially or completely absent on neutral MRI imaging, and preoperative extension MRI can be of great value to determine the accurate number of levels to be decompressed surgically. Modification of the type and extension of cervical decompression based on results of dynamic MRI should be assessed in future prospective studies. Thank you.
Good. Is Dr. Reddy around? Dr. Abhinandan Reddy?
Yes, sir. Yes,
Hi.
sir. I am available. Hello, sir.
Abhinandan, this paper is a good paper, but you are mentioning instability. So I understand that on your dynamic views, you are able to assess that something which looked less compressive is more compressive and needs to be decompressed. But can you call that instability?
I do understand it, but in this on dynamic MRI, what we mean by instability is the increased amount of compression of the spinal cord by the ligamentum flavum on extension. So I know X-ray parameters are different and MRI parameters are different to define the instability. In this study, by instability, we mean to say that there is more cord compression.
Further extension to that is that was there a study? Did you think about this or study without seeing those dynamic views, the surgical levels that you thought should to be decompressed, and after them, did that change clinically?
We haven't done anything comparative like that, but right now we are doing a survey wherein we are sending an images of a neutral MRI to the surgeons in and around the world, and later a dynamic MRI after a couple of weeks.
So that
yes, sir. We are doing a survey if there was a change in plan and how the clinical progression would be.
Good. Nice. Thanks, Abhinandan.
Thank you, sir.
So we'll go on to the next paper by Dr. Bhushan Sunil Hadole, Clinical Outcomes of Delayed Fixation in Thoracolumbar Spinal Trauma. Please play his paper.
Good morning. Today I'll be presenting about clinical outcomes of delayed fixation in thoracolumbar spinal trauma. There is a higher mortality associated with the spinal cord injury. Delayed presentation adds to this mortality. There is scarcity of literature regarding the same. So the purpose of our study is to look for factors which affect the outcome. Here is a retrospective study of 50 patients who sustained thoracolumbar spinal cord injury were treated with pedicle screw instrumentation more than 72 hours after the trauma. The minimum follow-up was of 1 year duration, and those with cervical spine injury and with inadequate data were excluded. We studied demographic data, the number and level of the vertebrae involved, thoracolumbar injury classification score and severity score, maximum spinal cord compression score, and signal changes in the cord, American Spinal Injury Association, maximum, then the lower extremity motor score, time interval between the trauma and surgery, and neurological evaluation at different intervals. The patients were investigated radiologically with X-ray, CT, and MRI. The patients are instrumented with pedicle screw. Even the fractured pedicle, if intact, was instrumented. The pre-op MRI was used to calculate the maximum spinal cord compression as follows. Then there was a mean follow-up of 33 months. The mean duration between trauma and surgery was 25 days. The pre-operative MRI showed edema in 34% patient, hemorrhage in 24% patient, and transaction in 14% patient. Maximum cord compression was less than 0.4 in 23 patient. The average TLX was 6.84 with a range of 4 to 10. The neurology at different intervals as per Asia scale showed 42.4% patient in Asia at admission, which decreased to 12.1 at a 1 year interval, while 18.2 patients in the Asia E at admission, which increased to 42.4 at 1 year interval. There were 26 patients, 12 patients, and 6 patients who had more than 1, more than 2, more than 3 grade Asia score improvement respectively at the end of 1 year. The LEMS score rose from 17.09 at admission to 33.86 at 1 year follow. 5 patients succumbed in the first year follow. All of them belong to the Asia group. To study the factors that were significant, the group patients divided into expired, ambulatory, and non-ambulatory. was found that presence of spinal cord signal changes, then the Scott transaction and average LEMS score at admission had statistically significant impact. Then there were improvement in the overall neurology in the entire group was statistically significant. There was another study which shows 14 out of 17 patients remained in the Asia A group at the end of 1 year follow-up. There was ladder function improvement in 8 out of 20 patients, that is 40% recovery. Another study showed 21.35% recovery, but the follow-up here was 5 months and the average age of population was 50 years, while our follow-up was 1 year with the average age being 34 years. On analyzing LEMS score, there was statistically significant improvement. Then when comparing patients who less than 1 week to 1 month and more than 1 month from the trauma to injury, there was no statistically significant improvement. Cord transaction and hemorrhagic contusion had poor prognosis. Our study highlighted that preoperative LEMS score, the presence of signal changes, and cord transaction are the important significant determinants of functional outcome at 1 year. Thus, our study concluded that there is still significant chance of neurological improvement after delayed surgery, and the pre-operative LEMS score at admission, the presence of signal changes, and the presence of cord transaction have an unfavorable bearing on the outcome. Thank you.
Thank you. Nice paper. So I understand that Dr. Bhushan, you're here, right?
Yes, sir.
I understand that basically the conclusion of your paper is that the radiological parameters of cord transaction, etc., are the main prognostic features which are seeing. And surgery, whether if you're doing a delayed stabilization and decompression, did that make any difference to the neurological outcome in these patients at all?
Yeah, so like the period after 72 hours there was no significant outcome. Like once the period of 72 hours is over, then the patients, no matter how long they are operated after that, there was some chance of improvement in the neurologist. It was basically for the patients who present late, like that they too have a chance of improvement. So we should go with fixation for such patient, decompression and fixation for such patient.
Great. Thank you. I would want Dr. Abhijit Pawar to join me now in for this session as well. We'll start with the next paper by Dr. Ghanshyam Kakadia on the effectiveness of beta-2 wound irrigation and intra-wound vancomycin powder to reduce surgical site infection in posterior lumbar spine surgery. Please place paper.
Hello everyone, my presentation is on role of betadine wound irrigation and intra-wound vancomycin powder to reduce surgical site infection in posterior lumbar spine instrumentation surgery. Deep wound infection is a serious complication of spine surgery. Wound infection may jeopardize patient post-operative outcome and increase financial burden. The most common organism that causes surgical site infection is Staph aureus. Incidence of surgical site infection in instrumented spine surgery is up to 0.5 to 7.7%. Local intra-wound vancomycin has high local concentration and no systemic side effect, and disadvantages is there is no local carrier to maintain that high concentration. Our study aim was to assess effectiveness of betadine irrigation with intra-wound vancomycin powder to decrease surgical site infection. It was an ambidextrous study. 80 patients included prospectively who received betadine irrigation and local vancomycin. 144 patients included retrospectively in Group B who did not receive betadine irrigation and vancomycin. Our antibiotic protocol was all patients received IV cephalosporin single dose before incision and post-operatively 3 days IV antibiotic and 5 days oral antibiotic. In Group A, also 0.3% weight by volume betadine irrigation diluted with normal saline followed by normal saline irrigation given. 1 gram local vancomycin added in up to 2 level spine surgery and 2 gram vancomycin added in 3+ level spine surgery. Criteria for surgical site infection are abnormal lower back pain with high CRP, MRI suggested of infection with pedicle screw fluid sign and biopsy and culture proven infection. Group A had 80 patients and Group B had 144 patients. Mean follow-up was 15.6 months. Only one patient had surgical site infection in group A and 4.16% patient had surgical site infection in group B who did not receive betadine irrigation and local vancomycin. There was no significant difference in mean operative time and intraoperative blood loss between the group. There was no significant difference in functional outcome and also implant-related complication. There is no any local vancomycin and betadine-related complication. Role of intrawound vancomycin for preventing surgical site infection remained controversial. Some studies suggested that vancomycin concentration in vitro more than 3000 microgram inhibit osteoblast and more than 6000 microgram leads to cell death. Minimal inhibitory concentration of vancomycin for MRSA is 1.5 to 2 microgram. In our study, minimal vancomycin concentration is 68.21 and the local vancomycin concentration is very high than minimal inhibitory concentration for MRSA. We concluded that local vancomycin powder has a high local concentration. Povidone iodine used against wide spectrum of pathogen. These both may not affect bony fusion and decrease incidence of surgical site infection. Local vancomycin has no systemic side effect and betadine irrigation has no allergy and hypersensitivity reaction. Thank you.
Good, nice paper. Abhijit, you want to ask anything? Can you allow Abhijit to unmute? Dr. Abhijit, you're muted.
Can you hear me now?
Yeah.
Were drains used after the surgery in these patients? What is the?
Yes, sir. Drain was used in all the patients.
But don't you think that if you use a drain, it would just suck the vancomycin powder which you have kept in the wound after the surgery?
Sir, we removed drain within 24 hour of the post within 48 hour post operatively, and we check intravenous patient serum vancomycin on post op day 3, and it was a mean was a 68 microgram. So after removal of the drain, we also check serum vancomycin concentration.
No. The whole paper is about local action of vancomycin and local action of betadine in preventing surgical site infections. So my question to you is, if you use a drain in these patients, the whole purpose of using local vancomycin powder is defeated, because it will suck the whatever vancomycin powder locally. The action is local; it's not systemic action, right? We are talking about local action of vancomycin. So if you use a drain, wouldn't it just aspirate the suck the powder, and the purpose of using the vancomycin is not served? That's what I feel. So do you think that we should not use drains in these patients if you use vancomycin powder, or what is your say on that?
Yes, sir. If we do not use the drain, then the local concentration of vancomycin is very high. But our old patient we have operated, that was operated by open surgery and long fixation, minimum 2 level or degenerative scoliosis. So we have to use drain on that old patient.
Good, Dr. Kakaria. Just one last question, a quick answer. Was this, did you take into account comorbidities between the two groups, like diabetes, etc.?
Yes, sir. We have taken comorbidities like diabetes and hypertension, and we taken patients that have controlled diabetic. So the mean level of sugar level is.
Okay. Thank you for your paper. We'll go on to the next paper by Dr. Vivek Bade on the revision lumbar spine fusion in patients who have undergone previous surgical procedures. Iliac crest autograft, irradiated cancellous allograft have similar effectiveness in terms of fusion rates, pain scores, and functional outcomes. So, can you please?
Good morning, everyone. I'm presenting revision of failed lumbar fusions, a comparison of iliac crest autograft and irradiated allograft. Pseudoarthrosis as a result of failed lumbar spine fusion surgery can result in disabling pain. Posterior procedures for failed lumbar spinal surgeries have resulted in reliably successful results. Recent studies have demonstrated the efficacy of irradiated cancellous allografts in revision lumbar spine procedures. However, no studies have compared irradiated cancellous allografts with autologous iliac crest autografts. It was a retrospective observational study. Comparison was done between 16 patients in irradiated cancellous allograft group and 12 patients in Illecrest bone autograft group. Retrospective questionnaire was done for evaluation of VAS scores and ODS scores initially and at 12 months of follow-up. So this was a case of 63-year-old female with L4, L5 and L5S1 leaf. Revision was done with irradiated allograft. This is a similar case of 35-year-old male. This is again a similar case of 59-year-old female using irradiated allograft. In results, we found that there was no statistically significant difference between allograft group and Illecrest autograft group in terms of ODS scores and VAS scores at the end of 12 months. 3 patients from the autograft group developed hematoma at Illecrest donor site. Pseudoarthrosis developed in 1 patient in allograft group. No patients developed surgical site infection at the end of 1 year. In conclusion, Illecrest autograft and irradiated cancellous allograft have similar effectiveness in terms of fusion rates, pain scores, and functional outcomes. However, Illecrest bone graft is associated with an increased risk of donor site related complications. Thank you.
Good. Thank you for your paper. So I understand that your paper basically reiterates what we already know, that in autograft, with the fusion rates are very good. However, there is some problem with donor site pain. And in allografts, the fusion rates may be slightly lower, as you had 1 case of pseudoarthrosis. But there is no problem with any autograft, any donor site pain related problems. However, only one comment is that this sample size is very small, and very few number of cases are being used to compare. So I'll go ahead. Yeah. Do you want to say anything before we go ahead? Thank you. Thank you for your paper. So we'll go ahead to the next paper again. It is by you again on CT guided biopsy and gene expert, which could be deceptive in infectious spondylodiscitis. Case report. Please play the video.
Good morning, everyone. I am presenting CT guided biopsy and gene expert ultra can be deceptive in infectious spondylodiscitis, a case report of mimic spondylodiscitis. The case report shows how CT guided biopsies and gene expert ultra can mislead the diagnosis in case of suspected infectious spondylodiscitis and should not be relied upon solely. A 15-year-old boy started complaining of back pain and fever. The local hospital prescribed some antibiotics and antimalarials without any response. There was worsening of symptoms. MRI dorsal spine showed collapse of D12 vertebra along with paravertebral collection and abdominal nodes. The CT guided biopsy of D12 lesions were performed. Histopathology showed acute and chronic inflammatory cells, but no granulomas or malignant cells were seen. TB culture was negative. Gene expert was not done. Bacterial culture showed Pseudomonas aeruginosa sensitive to most antibiotics. The patient received treatment with intravenous cefoperazone, sulbactam, linezolid, and ciprofloxacin. Transient improvement followed by recurrence of fever and back pain was there. Blood investigations showed high TLC, platelets, BSR, and CRP. Tuberculosis was suspected and empirical first-line anti-tubercular treatment was started. 2 months elapsed, but there was no clinical improvement. There was persistent fever, back pain, fever, weight loss. Persistent liver, spleen, and lung lesions were seen. Patient underwent bronchoscopy with lavage and endoscopic ultrasound-guided subcarinal lymph nodes and lung biopsy. Bronchoalveolar lavage was negative for cytology. Expert ultra was stress positive with indeterminate rifampicin resistance. Lung biopsy shows non-specific inflammatory cells. Lymph node biopsy showed gene expert negative. Biopsy was also showed in non-specific inflammatory cells. In view of positive expert ultra with indeterminate rifampicin resistance and no response to first-line drugs, treatment with second line was started. 2 weeks into the second line regime, no improvement was seen and there was worsening of symptoms. As there was no response to any of the treatment till now, decision to do CT guided FNAC from left para-aortic lesion was taken. CT guided FNAC of left para-aortic lymph nodes showed high-grade anaplastic tumor cells of lymphoid origin with plenty of mitosis. Diagnosis of stage 4B Hodgkin's lymphoma was done. Patient started on chemotherapy and Hodgkin's lymphoma. Repeat PET scan later showed complete resolution of FDG uptake in all lesions. Discussion. The initial diagnosis of Pseudomonas osteomyelitis in our case was probably due to contamination during the procedure or lab processing. The enhanced sensitivity of Expert Ultra as against the conventional Expert has come at the cost of reduced specificity. As per recent Cochrane review, the number of people wrongly diagnosed with tuberculosis by Expert Ultra are 3 times of that with conventional Expert. Result of the trace positive Expert Ultra in the bronchoalveolar lavage when other investigations are not supporting the diagnosis of tuberculosis should have been viewed with caution. This, however, does not apply to extrapulmonary sterile site samples like tissue biopsies or pulse where even trace positive is significant. Besides, indeterminate rifampicin resistance cannot be equated as possible rifampicin resistance. Conclusion. The case illustrates the need to avoid empiric therapy. Carry out repeat invasive procedures if so needed. Choose site or method of biopsy appropriately and interpret results of the investigations carefully when evaluating a patient with infective spondylitis. Thank you.
So, Dr. Bade, do you recommend for the routine spinal cases sending Gene Expert Ultra or not? Or
Yes,
just
sir. We do it routinely, sir.
so, like in case next time your sample will come positive for Gene Expert Ultra, how will you take it? Will you be kind of considering it TB positive or not? Or you will be considering it as a contaminant?
Sir, we have to check whether the clinical symptoms are correlating with the means clinical. We have to see the clinical and radiological features as well. Then we should take the decision to start the treatment.
Okay. Any other question, Abhijit?
So I'll ask the next paper to be presented by Dr. Harshit Dave on an analysis of telegram usage for collecting, storing, and retrieving data and medical records in patients with spinal disorders. Please play the video.
Good morning, everyone. In the next 4 minutes, I'll be talking about an analysis of Telegram usage for collecting, storing, and retrieving data and medical records of patients with spine disorders. Keeping patients' medical records that includes all details about him, including history, clinical findings, diagnostic test results, pre- and post-operative care, and patient's progress is important for effective patient care, follow-ups, and research purpose. It is also important in communication with other health professionals and sharing patient information with them. Smartphone applications are already in use by healthcare professionals to interact fast and efficiently and share medical information for effective patient management. The purpose of this study is to explore perceived benefits of Telegram usage for data collection, storage, and retrieving and its advantages for the same. A retrospective observational study was conducted in the Department of Orthopedics and Spine of a tertiary care hospital with high patient volume between July 2019 and July 2021. Telegram was used as the platform to share, store, and retrieve patient-related data. All the data that includes patient's age, gender, demographic findings, history, patient's complaints, clinical findings, investigations, clinical and radiological images, pre-operative and post-operative status, improvements, and follow-up evaluation were fed in a systemic manner. Patient's name, registration number, and mesh words were used for each case to facilitate easy searching and retrieving data. At each follow-up, patient's clinical findings and investigation, if done, if any, were updated. So the mesh words were used according to, in each case, mesh words were used according to the region, disease, if any syndrome, infection, tubercular deformity, the age of the patient, its neurology, if any neurodeficit, or the surgery performed and the complications, if any. So this is the illustration of how the registration number was used to search all the data of that person, including from the pre-operative to the follow-up. So this is the first image, shows the systemic, how the data was systematically fed, including history, his past history, examination finding, neurological findings, and the mesh words that were used. This was his pre-operative CT scan and MRI images and the videos that were uploaded. This is his pre-operative clinical images, intraoperative pictures and the videos, post-operative X-ray and post-operative clinical images, and follow-up evaluation. That all this data could have been searched only by using his registration number, and it was available to all the members of the group. This is illustration of use of mesh words for data retrieving by using words like claudication 244 results, neurodeficit 61 results, scoliosis 76 results, biopsy 60 results, MDR 7 results, MIST lift surgery 25 results. So this is overall compilation of different mesh words that were used and the results that were there on searching with the respective mesh terms. So in the results, benefit of using Telegram, collecting data and keeping records, data keeping, history, signs, symptoms, neurology, clinical images, radiology, X-ray, MRI, CT scan, post-operative and follow-up. Easy follow-up evaluation, thus enhancing patient care, resource for clinical research, access to the data on phone without even storing in phone, other drives, access to the data on multiple devices, easy data sharing, unlimited sharing capacity. New members added to the group can also access previous data, unlimited storage, maintains quality of pictures, surgical videos for particular case, closed group. It is a closed group and recover the data can be recovered and can be used for telecommunication and virtual data feeding. We conclude that the use of Telegram has many benefits in collecting, storing, and retrieving patient-related data and medical records, and when used systematically, it can aid in improving patient care. Thank you.
Harshit, so do you make a folder where all this information will go for the patient, or it's just a particular conversation, or how does this thing work?
So we had made a closed group of, first of all, good morning, sir. We have made a closed group. Good morning, sir.
Yeah, go ahead, please.
Yes, we have made a closed group that consists of the consultant with his team, and we any of the members who is seeing the patient in follow-up or pre-op, post-op takes the picture and upload it on the group with the specific registration number and mesh words. There's no need to make a folder of the patient. Whenever we want to retrieve the data, just go to the chat search, put the specific registration number or the name, and all the data comes one by one of the same patient.
So every message you will send in that, you need to put that patient specific registration number?
Every time that we do it.
Okay.
Every follow-up, we need to put that specific registration number, name, and mesh terms.
Okay. Satyan, Abhijit, any other question?
So what happens if we lose that registration number?
That's why, sir, we had,
yes, sir. And if you somebody loses the list of registration numbers, how do you search that patient?
Yes, sir. That is why, sir, we are using also names and mesh terms, and also phone numbers. So that are other ways to find the to search for the patient's data in our folders. So patient's number is always available with the patient, and if that is also not available, we can search with the mesh terms that we use for them.
Thank you, Harshit.
With the diagnosis.
Thank you. I will move on to the next paper by Dr. Maulik Langalia, Efficacy of Transforaminal Nerve Root Block.
Thank you.
Good morning, all the respected faculties. Myself, Dr. Maulik Langalia, and I would like to present here a study done on efficacy of transforaminal nerve root block in patients who had unresolved lumbar spine symptoms after total knee arthroplasty. At this moment, I would like to thank my consultant, Dr. Sanjay Londe, Dr. Ravi Shah, Dr. Meghna Patwardhan, and my colleague, Dr. Jahangir Peshwanji. In our clinical practice, we have noted that the degenerative osteoarthritis of knee and lumbar spine degenerative changes have occurred concurrently in about 60% of patients, which constitutes a majority of patients presenting in our OPDs in clinics with the knee pain as well as the low back pain. with some patients having a radiculopathies also. And various studies have shown that almost 90% of these patients have experienced relief of their spinal symptoms after total knee arthroplasty. In our study, we have aimed to determine the efficacy of these minimally invasive procedures like transforaminal nerve root blocks in this remaining 10% of patients who doesn't show any improvement after undergoing the total knee arthroplasties. The effect of TKR surgery on spinal symptoms, functions, and quality of life in reference to this all lumbar pathology have also been studied. In these studies, we have 120 patients who had degenerative knee osteoarthritis as well as lumbar spondylitis. We have followed these patients for up to 24 months and have done the evaluation based on Osteoarthritis Disability Index as well as the visual analog score. All the patients have undergone pre-operative X-rays, radiological imaging in the form of MRI also if the patient shows any pathology of lumbar spine. Patients who had no improvement in their lumbar spine symptoms were studied with respect to improvement with minimally invasive procedures like transforaminal nerve root block. These all the procedures were carried under fluoroscopic guidance by a pain management specialist, and all the patients were followed up and taken the records at the end of 1 month as well as the 24-month period at the end of 2 years. All the patients are also given a self-addressed evaluation form to rate their lumbar spine problems. We have a result that 90% of patients out of this 120 had relief of the lumbar spine symptoms after total knee arthroplasties. Of the 12 patients who had no improvement, 10 did improve with minimally invasive procedures like T and RB, which constitutes approximately of 84%. The Osteoarthritis Disability Index has improved from 44% to 16% with a significant p-value, and the mean VAS score has also improved from a pre-procedure of 7.2 to the 1.6 mean post-procedure. One patient had no improvement with this procedure and had underwent an open procedure in the form of spinal decompression as well as fixation. One patient has declined any intervention. We have a conclusion that these minimally invasive procedures are helpful in the relief of symptoms who have continued lumbar spine symptoms after TKR procedures. And we have a significant number of patients who have undergone the TKR along with the coexisting degenerative changes of spine have also experienced a good relief of their spinal symptoms after TKR. Patients having both the osteoarthritis knees with the degenerative spinal pathologies should undergo and should better to address the osteoarthritis knee first, followed by the spinal problems if required with the minimally invasive procedure if doesn't get improved with the open procedure or as advised by the spine specialist. I would like to thank you for allowing me and giving me the opportunity to present my study, and thank you. Thank you.
Yeah, I think Dr. Maulik is not present here, but
Okay.
I had a few comments about the paper. I think maybe he was expecting the comments and so he did not attend. But
Right.
there are a few, these comments are for him to improve actually. There are a few doubts in my head. Number one was that whether there was a spine pathology to begin with,
Correct.
and when many times we have patients who have got some degenerative changes or stenosis in the spine as well as knee issues, and or whether they just had back pain and or they had it later on after the surgery was done, they saw that some symptoms are remaining. The second point was that he has not differentiated between back pain and leg pain, whether these patients had only back pain symptoms or they had radicular symptoms. So these were the things which I thought about. Your thoughts, Abhijit?
Yeah, and the number is quite high, and the number of patients having back pain, I mean lumbar symptoms along with a knee problem is pretty high. So I think it is good to identify these patients to begin with. That do you really have a lumbar stenosis? Because the transforaminal block is a temporary way of postponing the problem. It will just postpone the pain for another couple of months, so it will come back again. The patient will be overall unhappy if you don't treat the spine problem to begin with, or at least the patient knows it before the surgery that he has a lumbar spine problem, and which can lead to incomplete resolving of knee pain post-operatively.
Yeah, so we've not even discussed about the degree of spinal pathology, pre-operatively, that we can, sometimes we say that there is some degeneration, but it's not causing any symptoms, or whether there was actually stenosis. So it's a little bit confusing. Amit, do you want to add anything?
Yeah, the other thing that they tried root block, which is a very specific procedure directed to a particular root, compared to a lumbar epidural. Lumbar epidural is a diffuse treatment modality which will kind of affect all the levels in the lumbar spine. Root block is a specific targeted, so you want to block L4 root on the left side. That's what only you do. So how did they identify that? And like in a patient, so means that the pathology was beforehand only identified and it was not addressed.
Yeah. So we'll go on to the next paper by Dr. Sharvari Gunjotikar on the timing of vertebroplasty in osteoporotic vertebral compression fractures. Please play her video.
Hello everyone, my name is Dr. Sharvari. My topic for today is timing of vertebroplasty in osteoporotic vertebral compression fractures. While treating osteoporotic vertebral compression fractures, we're faced with a number of challenges. These patients often have a very poor osteogenic potential. The dorsal-lumbar junction is a high-stress zone. There are high chances of non-union and kyphosis. This may require major surgery and instrumented fusion later. These patients often have a number of comorbidities which predispose them to infection. There are high chances of immobilization-related complications. Vertebroplasty, on the other hand, has a number of proven benefits, which include quicker pain relief, earlier mobilization, fewer immobilization-related complications like DVT, UTI, and thromboembolism. However, the ideal timing at which vertebroplasty should be done is a matter of constant debate. So we carried out a PubMed search using the keywords acute vertebral compression fractures, vertebroplasty, and osteoporosis. After reviewing 107 abstracts, we included 16 studies in our review. We included 1,836 patients, of which majority were females. The range of duration of symptoms was from 2 days to 12 months. Majority of the studies showed beneficial effect of vertebroplasty. However, these two studies showed no beneficial effect of vertebroplasty, possibly because of longer duration of symptoms in these patients. Coming to the pain scores, vertebroplasty patients had significantly better pain scores in immediate postoperative period as well as at later follow-up when vertebroplasty was done between 3 to 6 weeks. Vertebroplasty patients had lesser analgesic requirement, a shorter length of hospital stay, and a lesser time of bed rest as compared to other forms of intervention. The functional outcome was better when vertebroplasty was done before 6 weeks as compared to when it was done before 9 weeks. Coming to the radiological outcome, we found that there was a better correction of fracture-related kyphosis when vertebroplasty was done before 6 weeks. There was also lesser loss of vertebral body height when vertebroplasty was done before 6 weeks. Coming to the complications, vertebroplasty patients had lesser number of medical as well as neurological complications. We commonly use DEXA scan to estimate trabecular bone density for osteoporosis. We have recently conducted a study in our unit where we found that DEXA scan significantly overestimates trabecular bone density. We found that the mean T scores were much higher when for DEXA scan as compared to quantitative CT. So on account of these factors, we recommend vertebroplasty within 6 weeks after the fracture. This is on account of better reduction in pain scores, improved function, lesser analgesic requirement, better correction of fracture-related kyphosis, and thus sagittal balance. However, how early should vertebroplasty be done, whether at 3 weeks, 4 weeks, 5 weeks, is a matter that needs further analysis. Thank you for your time.
Hello, all of you. Myself, Dr. Tosi.
Thank you, Sharvari. So the most important question you yourself has put at the end of the talk, that how early can we do, and I think definitely none of us propose it before 3 weeks. Was there any vertebroplasty is the pathology for vertebroplasty is a quite very wide spectrum. So was there any specific type of lesion, Kummel's lesion, or the degree of collapse which was determining how early or how late it can be done in the literature? Based on the you're on mute, Sharvari.
There was, sorry, sir. There was no mention regarding the amount of collapse that was there in these studies, sir.
And they were all pure vertebroplasty. They were not kyphoplasties, correct?
One study included kyphoplasty, sir.
Okay. Any short
Yeah,
fixation?
Sharvari, our comment was actually that you should have differentiated between these different types of fractures because the results completely change with them. So it's not that just any compression fracture can be taken as one big gamut. And so we are now, as we have been doing vertebroplasty since the last few decades, couple of decades or so, we know which ones will do well with them and which ones won't. So for the further study, I think you should differentiate between that. Thank you for your paper.
This was
We'll go on
meta-analysis or Sharvari?
Yes, sir.
Was this a meta-analysis or it was an analysis of the own patients?
No, sir, it was a meta-analysis.
Okay.
So we'll go ahead to the next paper by Dr. Shashi Sekhar. By Dr. Tausif Ahmed Shikalgar. On pot spine in children, does drug resistance make any difference?
Hello, all of you. Myself, Dr. Tausif, and I thank BSSCON and all of my colleagues to give me this opportunity. This is case of 14-year-old female child who is nil neuro at the presentation, and at 3 months of starting first-line treatment, this is her MRI. It suggests catastrophic progression. This is case of 3-year-old male child who was on first-line treatment for 6 months, and this is his MRI at the 6 month, which suggests poor response or no response. Aims and objective of this study is to compare non-operative treatment in patients with drug-resistant tuberculosis and non-drug-resistant tuberculosis in pediatric pot spine. Inclusion criteria is the children who has presented to OPD with clinical and radiological features of pot spine, those who has completed prescribed course of treatment and has minimum 2 years of follow-up. Diagnosis of TB was made on clinical and radiological features, and on each time sample was sent for TB, MGIT, gene expert, and histopathology. Once sample is collected, empirical first-line treatment was started by pediatric infectious disease specialist. When MTB was detected, treatment was given according to DST. When MTB was not detected, treatment was given according to clinical radiological response. Response to the treatment was monitored on clinical and neurological examination, on X-ray by K angle, MRI, and conversion to surgery. Of 118 treated patient, 51 patient, that is 43.2% patient, were drug resistant. Of 90 conservatively treated patient, TB, MGIT, and gene expert was positive in 71 patients, in which treatment was given accordingly. TB, MGIT, and gene expert was negative in 19 patients, where empirical first-line treatment was started and their response was monitored. Good response was shown in 17 patients, and they were continued on first-line treatment. Poor response was seen in 2 patients, where presumptive second-line treatment was started. Indeterminate result was shown in 3 patients, where first-line treatment was given. Good response was shown in 1 patient, where first-line treatment was continued, and poor response was shown in 2 patients, where presumptive second-line treatment was started. Of 90 conservatively treated patients, 41.1% patient was drug resistant. On comparison, there was no significant difference between demographics, number of vertebral body involvement, pre and post neurological status, and kyphosis angle at the presentation. There was significant difference in final kyphosis angle and the rate of complications. Complications were noted in terms of progression of kyphosis in 84% patient in drug-resistant group, conversion to surgery in 73% in drug-resistant group, and poor response to treatment in 79% in drug-resistant group. On the reviewing literature, there are few studies with very few number of cases. Limitation of this study include it is a retrospective review and minimum 2 years of follow-up. To conclude, this is largest series of drug-resistant tuberculosis in spine in children with 51 cases. We recommend TB-MGIT and gene expert to be done in all cases of tuberculosis of the spine. Conservative treatment is effective treatment. However, close monitoring is required in drug-resistant cases as complication rates are known. Thank you.
Good morning, everyone.
Thank you, Dr. Tosi, for your nice paper. One question I have is what was the duration of treatment both for non-drug resistant and drug resistant cases? You're on mute, Dr. Tosif, you're on mute.
Am I audible, sir?
Yeah, you are.
Yeah, good morning, sir. So the treatment as per paper suggested, it is directed according to infectious disease specialist, and average duration of treatment in non-drug resistant group is about 1 year, and in drug resistant group is about 2 years.
So after finishing the treatment, most of these complications and conversion to surgery, they were during the treatment period, or they occurred after the treatment was over?
So it was during treatment period. Most of the cases like conversion to surgery is during treatment period, and we have excluded that group as exclusion criteria said that if patient is converted to surgery, but we have recorded it in the complication group rather.
Okay.
So I have one question.
Yes, sir.
The MRI pictures which you had shown had a significant, epidural collection. So if these children had neurodeficits, did you still continue conservative management, or what was the indication for conversion to surgery in these children?
So indication for surgery is new onset neurological deficit or like sudden onset paraplegia, or like still worsening of K angles on the X-rays.
So none of these patients had needed surgery. This 90 patients which you had shown in this study.
So total 118 patient we have studied, sir, out of which 28 patient required surgery. During treatment, 15 patient required surgery, of which 11 belongs to drug resistant group and 4 belongs to non-drug resistant group.
Okay.
Thank you, Tosif. We'll move on to the next paper by Dr. Uday Kumar.
Thank you, sir.
Impact of COVID-19 pandemic on the management of osteoporotic vertebral fracture. Uday, talk, please.
Good morning, everyone. I am Dr. Uday Kumar. Today I am going to present a paper on the impact of COVID-19 pandemic on the management of osteoporotic vertebral fractures. Osteoporotic vertebral fractures is a major public healthcare issue in India and the world, as they are associated with high morbidity and mortality. Delayed treatment of these fractures can increase the morbidity and mortality in these patients. Because of COVID-19, there is a significant cancellation of elective surgeries in the last year. Because of these, there is a delayed treatment in osteoporotic vertebral fractures. Our aim of the study is to investigate the impact of delay in treatment of osteoporotic vertebral fractures and to evaluate its possible influence on the clinical outcome. Our study is a multi-center retrospective study done in 2 tertiary care centers from April 2020 to June 2021. In our study, 106 patients are involved. Their pain and functional level assessed with VAS and ODA scores. Inclusion criteria are those who are advised of vertebroplasty and surgery and who underwent delayed treatment are included in our study. Exclusion criteria is those who underwent immediate treatment, those who are suffering with pathological fractures, osteomyelitis, and coagulopathy. According to German Society for Orthopedics and Trauma, they are graded in from OF1 to OF5. OF1 is the low grade and OF is the high grade. Management protocol in our study is out of 106 patients, 44 patients who comes under OF1, we advise the conservative treatment. All of them showed good improvement after 3 months of follow-up. 32 patients who underwent who comes under OF2, we advise the vertebroplasty as a primary procedure. All of them underwent delayed treatment. In these 27 patients came after 3 months follow-up. In these 26 patients further needed vertebroplasty as the primary procedure. 25 patients who came under OF3, we advise vertebroplasty as the primary procedure. In these 21 patients came after 3 months follow-up. In these 18 patients further needed vertebroplasty as the primary procedure. 4 patients who comes under OF4 and 2 patients comes under OF5, we advise primarily stabilization as a procedure. 4 patients underwent immediate treatment, 2 patients underwent delayed treatment. In these, 1 patient further needed stabilization as the primary procedure. In our study, 56 patients underwent delayed treatment and managed conservatively with bed rest, calcium and vitamin D supplementation, oral bisphosphonates therapy, calcitonin nasal spray. Injection teriparatide advised to all patients, those who are willing and those who are avoidable. This is an L1 wedge compression fracture showing in X-ray and MRI. We advise vertebroplasty as a primary procedure and treated accordingly. In this case, X-ray and MRI showing L1 wedge compression fractures who comes under OF4, we advise stabilization as the primary procedure and treated accordingly. This is the VAS and ODS course of the initial presentation and after 3 months of conservative treatment. A VAS score is 9.1 and at the initial presentation and 8.4 after 3 months of conservative treatment. It is not significant. The p-value is more than 0.5. After this, we underwent vertebroplasty and we assessed the VAS and ODS scores after vertebroplasty. There is a significant change in the VAS and ODS scores. The p-value comes under less than 0.05. Our study has higher coordinates with other studies. Our study done on 45 patients with vertebroplasty. In these, 96% of the patients has significant improvement in pain and function. Despite of delay in 3 months in treating OEF with vertebroplasty, we could obtain good relief of pain and improvement in function as judged by VAS and ODS scores. Hence, we strongly advocate vertebroplasty for OVS even after initial delay in treatment in indicated patients. Thank you.
Thank you, Uday. Some of my colleagues, they swear by teriparatide, and COVID has given us this scenario that where many of these patients were postponed from having to undergo the vertebroplasty, and many of them, as per your protocol, were started on teriparatide. So, did you see any patients who, in your existing protocol, were actually in need of vertebroplasty to start with, but because you started them on teriparatide, their vertebroplasty was avoided?
Sir, in our study, we only 8 patients are willing to take the teriparatide, sir, because of affordability issues and patients are not willing to take daily injections. Only 8 patients are willing to take the teriparatide. In these, 4 patients shown good improvement from who comes under OF3 and OF2 fractures.
And they avoided surgery or they ultimately?
They avoided surgeries. Those who are taking teriparatide, 4 patients avoided surgeries.
Okay, and was it teriparatide alone or it was with some bisphosphonate or denosumab also included?
Sir?
Was it teriparatide alone for treatment of osteoporosis or you included bisphosphonates, any other medication, denosumab?
Some patients are also willing to take bisphosphonates also.
Okay.
In bisphosphonates, most of the patients are needed vertebroplasty procedure after treatment.
Okay. Abhijit,
I have one question. Yeah, so all these 50 patients in the study are all post-COVID patients?
No, sir, they are not a COVID patient, sir. They are during pandemic, they are suffered with vertebral fractures.
Oh, so they didn't have COVID infection, so you don't have any suggestion?
No one get affected with COVID, sir.
They were just delayed because of the COVID situation.
Delayed due to COVID pandemic, sir.
All right. Okay.
Thank you, Uday. Thanks a lot. May I invite next speaker, Dr. Ujjwal Kumar Biswas, to speak on high-grade spondylolisthesis instrumentation.
Good morning. Today I am going to present a clinical study on posterior body instrumentation for management of symptomatic grade 2, grade 3 and grade 4 spondylolisthesis. The aims and objectives are to assess the study of functional outcome of the decompression and posterior instrumentation of spondylolisthesis. To study the communication occurring with this technique in 4 54 patients in our institute. The operative treatments of indications of compression of sleep, structural deformity, neurological deficit, and interface pain not responding to conservative management. Components of operative interventions are reduction, decompression, bone fusion, and instrumentation. The risk factors are hereditary trauma, weightlifting, and obesity. Clinical complaints are low back pain, radiculopathy, motor weakness, numbness, bowel and bladder involvement. Clinical findings are step deformity, spine tenderness, motor deficit, sensory deficit, diminished ankle results in positive straight leg raising test. Level of spondylolisthesis mainly occurs in L5, S1 and L4 vertebra over L5 vertebra. In surgical outcome, more or less 88% patients are satisfied. Females are more satisfied than male patients. Patients in the age group of age group between 40 to 60 years of age are more satisfied than below 40 and more than 60 years of age. In our study, majority of the daily wage workers, farmers, and housewives have a favorable outcome to surgery. In our study, 22% patients had body mass index more than 30. Within this, 66% patients reported a favorable outcome to surgery. In our study, 96% of patients reported improvement in their low back pain. 81% of patients improved motor strength. Numbness improved 90% of patients, and bowel and bladder involvement improvements in 66.6% of patients. In our study, 100% of patients with spondylolisthesis at the level of L4 and L3, L4 showed improvement, while 87% of patients at L4, L5 level showed improvement. The most common complication is intraoperative dural tear, post-operative superficial infection, significant intraoperative blood transfusion given only one patient. In our study, females are affected more than males, more commonly in the age group of 40 to 60 years. Low back pain are the most common presenting symptoms, followed by radiculopathy. Spondylolisthesis was found marginally more at L5 S1 level, followed by L4 L5. Results are equally good in both males and females. Dural tear is the most common complication. The above results indicate the most of our patients are satisfied with posterior for management of the high-grade spondylolisthesis. Weightlifting was associated with higher incidence of high-grade spondylolisthesis, obesity with poor outcome. Thank you.
Thank you, Dr. Biswas. If I may, did you have any post-operative increase in radiculopathy because of the root traction after the reduction of the listhesis?
Sir, good morning, sir. Some patients show the post-operative pain, not only post-operative pain, and that increases after post-operative period, but maximum of patients, mainly delivery workers or housewives, relate pain mostly.
And one thing we missed from your presentation is that these spondylolisthesis, what was the primary diagnosis in them? Were they lytic listhesis? Were they degenerative listhesis only, or the primary etiology was missing?
Actually, it is lytic listhesis mainly, lytic.
Okay, thank you. Abhijit? Abhijit, do you have any question?
No questions. Thank you. Yeah.
So with Dr. Viswas's talk, I would like to conclude this session. I would like to thank all the presenters who present their hard work at the Bombay Spine Society's conference. And I'm very happy to see that nowadays we are presenting more and more free papers rather than those expert talks. I would like to conclude this session here, and we can move on to the Hall A with the ongoing academic activities. Thank you very much.
Thank you, everyone.
Bye-bye.